So in lab, we had this one individual today that had a bilateral pathological problem. Sheila had this positive adduction drop test on both sides, and more likely yesterday when you tested her, she had a negative extension drop test on both sides. She snaps in bed when she rolls around. She rolls around, her right hip snaps. Her left hip's probably loosey-goosey. And if I were to check IR today, I don't know what it was like yesterday, I think it would be somewhat limited because you can't corkscrew in because you can't cover up that femur well enough. Your posterior capsules are snug and tight. Do you mind if I show everybody your yoga instructor, a good one? So she's got her abs working, she knows her body really well, but she's still not centering well enough into her socket. How am I doing, Sheila? Does that make sense? So what a great segue into this next section in your manual. Because then I told her this is a very common problem in clinical settings or in strength building settings. Capsules that are too tight posteriorly. Very common problem. Everybody with me on that, Lydia? You're going to see a lot of this. So I really like to talk about it. So then I said, let's go to your manual and let's go to page 56 where the inhibitory program begins. And Jen and I want to make sure this section is given some time. We want to spend some time on this today. So you let us right into it. Let's go to the very first one. The very first one on this page, on page 56, says left TFL inhibition. Wasn't it interesting, Chad? She couldn't shut them off. Her TFLs were yelping at us. They wouldn't let go. They're trying so hard to become your anterior glute med and glute min because of the mild kinematic position that that TFL is in. That is your glute med and glute min. That is what you're using instead of the glute med min. So we want to consider using these recommended inhibitory techniques if the patient activates their TFL before or after reposition with FAIR. Check, we saw that. Is engaging their TFL with any PRI non-manual technique progression. We've seen that a couple times today. Somebody said, you know, was it you, my outside my leg? Pat, was it you? Who was saying my outside my leg is still kicking in?
She.
She does?
Yeah.
Which one, Sheila?
Yeah.
Okay,
Left.
So my outside my left leg, my TFL is going all the way down, my band. The TFL is made from the bicep femoris and, sorry guys, the TFL is part of your vastus lateralis and part of your hamstring complex, and it's just connected with that tensor fascia all the way down to the lateral side of the patella. You can't shut it off. The TFL connects kind of to it. It's engaging with TFL with any techniques you do. You're engaging that TFL. So Sheila, any of these would probably be good for you. Let's take each one. 90-90 ball. Chad, whoever worked with her did a great job. Ball was between your leg, and we were trying to get you to not only just do a hip lift, but trying to do a hip shift. Do you remember that, Sheila? We were trying to get you to figure out how to shift back and forth. Didn't go so well, Sheila. So then I said, well, why don't we try taking your left knee and keep it in by taking the left foot and placing it out a little bit. Chad, we could have done that on the right side too, because we have that problem on both sides. We engaged IR passively to help shut off your TFL need to internally rotate that femur. We disengaged the TFL by passively putting you into IR. Now at that point, that posterior capsule's snug. It's saying, whoa, my ischiofemoral capsule and my ligament back there say, which is external rotation, is saying, whoa, you just put me on stretch. Man, that's snug. So now I got a capsule that's tighter and a ligament that's also tight. So you're putting them on stretch right off the bat. And then we're gonna have you start to shift. You did okay, wasn't impressive. You still felt some pinch. Another one you could have done would have been this clam type work. I could have had you work supine hook lying synchronized resisted glutes. I could have kept your foot on that block, same position, and I could have turned on your glutes. This kind of sounds kind of cool. Reciprocal inhibition. I'm going to turn on your glutes, get your glutes to kick on, and then I'm going to have you go passively into IR. So I'm going to facilitate and stretch, or facilitate and inhibit. I'm going to facilitate a glute max, and then I'm going to let it shut off. Or facilitate an external rotator called contract. Remember these P&F days? Contract, relax. Some of you in the room won't know what that means. Some of you might. Did you get contract, relax in school? Contract, relax. Externally rotate, come back. Is the band pulling you in now? Yep. No TFL has to work on that one. Contract, relax. Contract, relax. And every time you relax, you want those knees to come what? More in. And what could I do to those legs? Start spreading them if I wanted to, those 2 feet on that block. But just the activity of contract, relax makes sense. Sheila, I highly recommend that you try that. And then you go to the next one. I could put you on your side. And I could put you on your side and have you do a left anterior glute med work while you're pushing into that post of that chair or table or whatever you might be next to. Now I'm doing a 90-90, but I don't have your feet on the wall anymore. I have the back of your thigh on a post, Sheila, which means just keep your thighs on that post. Do you follow me? Hold it there. And internally rotate one leg, turn around, do the same thing on the other side. Because the minute that hamstring that's now in a activated state, because you see the knee flexion, it's a 90-90 position. Is that a loose packed position? Yeah, it's a 90-90 position. We're not going to use the wall anymore for your feet to figure this out. We're going to use glute meds to figure it out. And we're going to put a band, we're not going to put a band on you, but we're kind of putting a ball between you. You easily could put a ball here, Sheila, easily. Sheila, doesn't that look familiar? We put your foot passively out. Remember that? It doesn't look familiar? And Sheila, that would be a good one for you. That'd be a good one on both sides. And then look at the next one. What a complex activity. Whoa! I got you on your tummy. First of all, you've never seen anybody on their tummy today or yesterday. I got you on your tummy, Sheila. I've got a band around your 2 thighs to kick in your abductors and your glutes a little bit to pull you out. And I've got some weight on your leg, and that weight's going to prevent that band from running down your leg as you bend it. And the weight's going to give you proprioceptive input of where your hamstring is. And the band is going to make you IR as you are getting maximum distraction. You know what I see? I see a bolster between your 2 thighs, keeping your thighs what? Apart, which is what you told me felt pretty good. So I'm teaching you how to go IR, IR, IR with glutes that are on, that abduct, abduct, abduct. If I abduct an IR, you aren't going to flex an IR. TFL has to what? Because the antagonistic muscle called the hamstring is working instead of the agonistic muscle called the instant gratification. Guarantee you will not have any hip flexor kick on in that position. But it's a little complex. I got 2 bands on you. I don't want you to do an anterior pelvic tilt either. But for you, Sheila, that may be the cat's meow, because you're laying there, you're not doing anything. Your hamstring is now at a maximum contracted state, because you're not going into hip flexion, you're going into more hip what? Extension. And the knee is what? Bent. So I'm getting maximum hamstring, I'm getting some medial hamstring, abduction from the glutes, because you see that band around you, IR with resistance to shut off your TFL. All of this is TFL inhibition. Okay? Now, we can do lots of other things. And, you know, Jen, I know Mike does this. Mike's really good at shutting off the TFL. What was the thing he demonstrated the other day? What position was he in? And they were just shaking.
It was more of a supine 90-90 with feet on a chair, but doing extra FD.
It was basically this B. He did this B with his feet on a chair. This B, he'll tell you, if you can get this external rotation going, it'll definitely shut off a TFL. The problem is, I love it, but you still, Chad, I know us, we still got to get into AFIR without that TFL kicking in. So I got to keep you somewhat in a neutral state versus your feet all the way out here. It'll definitely shut your feet off. He gets these people shake, rattling, rolling, and it definitely shuts off the TFL. Glutes are kicking in. But I still got to get you back in that posterior capsule. You still got to come inward and get it. So any way you shut off the TFL other than these 4 ways is great as long as you can get that AFIR. Okay, that's TFL inhibition, okay? We're gonna keep going here because posterior capsule's coming up, Sheila. Sheila, I'm using you a lot, is that okay? Is this too much? Okay, next one. Okay, consider using these recommended inhibition techniques that the patient has. The difficulty finding and feeling the left adductor. Underline that. Boy, Sheila, you did. It's difficult to find it, okay? Or difficult, or has a decreased right FAER, can't externally rotate. And I don't know if you had that problem or not. Has overactivated the right adductor when attempting to adduct their left femur during a level 2 of the Aruska adduction lift test. Overactivated the right adductor. In other words, their timing is off. They're using the right adductor too quick. Or basically says, my right adductor is always on. You know, walks around and says, I can feel my right adductor, but Karina, I cannot get my left adductor to work like my right adductor, okay? Any of these activities, I love this activity. Sheila, you ought to consider this baby. Supine hook lying, let the leg lay out on a pillow, push into that leg. Okay, that's shutting off the right adductor. And as you do it, keep the left hip back. So you're learning how to shift into left AFIR because part of your problem is your adductor magnus isn't letting go. So by getting your right leg, you're not popping out anymore. You're popping out this way. That femur's coming the other way, not forward and out, but you're laying out and it's popping forward and it would be forward and up, okay, depending upon how you look at it. I would consider this one, Sheila, with you. I'd want to actually stretch your right side out a little bit so you can shift over into the left. I don't think I would stretch the left one out on you ever. I would not stretch out the left adductor ever. I probably wouldn't do that on anybody. I don't think I've ever done that in my life. But I would definitely consider this. Or the supine right adductor magnus stretch. Getting that whole posterior capsule stretched out on the left with a right adductor magnus stretch. So externally rotate your right leg, slide that leg down, keep the knee up as high as you can when you do it. You'll feel a nice stretch on the right adductor magnus. And write down the word left posterior hip capsule. That's a great activity for left posterior hip capsule with concomitant right adductor magnus stretch. Sheila, everything you're seeing here, you could do. Everything here you could do. It would not hurt you a bit to do these. Left side lying, right extended FA abduction with left abdominal coactivation. So she's on this side, she's got a bolster underneath her leg to keep her up in the air, keep that knee above this hip, left abs. She could push into that bolster if you want to know the truth, Chad. And then all you're going to do is try very hard in that position to abduct this right leg, and I would keep that adductor on. However, if your TFL kicks in, or if you can't pick this leg up, don't worry about it. We're doing it for right adductor inhibition. How about this one, Chad? Lay the right leg there. Don't move it. Bring your right hip forward. Don't move it. Right glute max it. Activate your left abs. Turn your right foot in to stretch out your external rotator adductor magnus on the right side and breathe. And feel the stretch. How could you get a bigger stretch out of that right adductor, Jen?
Push the right leg to the wall.
Isn't she amazing? That's it. And in fact, I think the handout says that, doesn't it, Jen? I am so glad you're permitting us to go this slow over these techniques right now. I'm so glad. I'm so glad it's being filmed. Because these are just as important as anything else we've done in the last 2 days. Because the word says inhibition. Your program regardless of what you picked with patient A or B, just went what, Eric? Way up, because we're shutting off things that are getting in your way. You're inhibiting interferences that you can't overcome. I'm so glad. I'm in your way a lot, aren't I? Can you see it? The standing left knee flexion in right FA abduction is a great inhibitory program as I kill myself. That's left posterior capsule stretching with, again, right adductors being kind of released and stretched out. And that's right trunk rotation with left ab activity. It's a wonderful thing to do during the day. Mom with those 3 kids, Katie, every day, a little bit of that goes a long ways, a long ways. Love that. Okay, let's go on to another one. This to me is myokin supplemental number 1. This is Bobby, this is those Army people. Their butts are tight. Do you follow me? Their glutes are developed. This is big. Consider using these recommended inhibition techniques if the patient has the following. Decrease left FAIR, no IR. Remember that football player yesterday just had limited IR? Has a 1 for an adduction lift test or lower. I mean, they just cannot even begin to rotate. They're laying there. They can't even get in the position. They can't even get into a position without their body rotating all the way what? Back. And I swear you're going to see these people. These are people that are looking pretty good shape. They're proteined up. They're muscular bound, and they're rigid. I love this whole program. Here is some of my favorites. All four glute max, all 4 right glute max. This towel under this left leg is shoving that left hip up with this right glute max, pushing you over to that left side. No TFL activity. Sheila, it's got your name written all over it. Push down those hands, find those abs, go over to the left side with the right glute max and feel the beauty of someone pushing that socket back like we were doing over there, but this time it's a towel. I'll stop a minute on this one. Is there any questions? Drew, does this one make sense? All 4s in your program would be awesome. It's a great program for anybody to get into. Look at how those people are going to crawl around and creep around in your programs. Okay, they got to. Standing posterior capsule stretch, Sheila, every day. Left foot on a block, whether it's a 2-inch, as Jason showed you this one and all. Shift back all the way to the left side, get your left knee in, and feel the stretch. If you've got a groin that's talking to you, then what you got to do is you got to figure out the sweet spot. Would someone tell me what the sweet spot is? I know 2 people can tell me what a sweet spot is. What's a sweet spot? How did you find the sweet spot? You dialed the radio, you tuned the radio in. What did you do? You went forward and back until you figure out there's no what? No pain. Remember that? Basically, you kind of play with it until you figure out, whoa, got it, my sweet spot. In other words, with the knee towards knee, knee to knee, you figured out the spot. By the way, Jen, I want that on there when we do the taping. You figured out a little sweet spot. If I bring my right knee too far forward, I hurt. If I bring my right knee all the way back, I hurt. But if I bring my right knee just mama bearish, I got it. I got it. This is kind of the same thing. I'm going to bring my knee back a little bit. Oh, it hurts. I'm going to bring my knee forward. Oh, it don't hurt. If I go forward too much, it hurts. I got a little sweet spot. Boom. I can glide right over it. I can glide. Sometimes it's not the 4-inch block that may help you. It's a 2-inch or a 1-inch. You're going to figure out a beautiful position to get into where you can slide right over that femur. Does that make sense to you, Sheila? Want to say anything about that one, Jen, at all? Page 52. Standing wall supported ischiofemoral. Oh man, Sheila, this is a killer. But man, I tell you, I've used this in a lot of volleyball. A lot of people that are really tight, stringy. Put a little bolster between you. Round out your back. Shift back into the left. That bolster is a pivotal shifter. It shifts you back into that capsule. Right knee goes forward. There's a block behind the heels to kind of, Katie, give you the sense of where is your hamstrings. That block behind that heel tells you where's your hamstrings. This goes back to my early days, Eric. A block behind the heel gives you hamstring awareness, heel calcaneal awareness. I'm surprised we haven't talked about it until this point in the course. And she's laying on that wall. She's shifting her knee back. She's got that heel on that block, and she's trying to get that right knee forward. And as she brings that right knee forward, Sheila, you're going to feel somebody pushing it back into the posterior what? Capsule. You just work it, you just work it, you just work it. As you squeeze that knee together, it's like a knee toward knee activity, and you're trying to squeeze that knee together, and as you're doing that, you're going to feel capsule what? Stretch out. All of these are written pretty well for you on the technique, page 52 and 53. They're all written out pretty well. This is a standing supported respiratory AFIR reach. So he's breathing in and he's shifting back, getting that left hip capsule to open up posteriorly. You can almost look at the snippet and just feel it. Let's make sure on page 54, everybody go to page 54, okay? Jen, are we doing okay for time? Doing okay? Page 54, if you go there just for a moment. And just, can I look over your shoulder? Do you mind if I just look over your shoulder here? Exhale through your mouth as you push your left midfoot and straighten both knees. You should feel the muscle in the front of your left thigh and left outer hip engage. Repeat this breathing sequence. This is totally a breathing program for that technique. This is a great technique to do. This is a technique you could do on both sides every day for those people who are really, really, really tight. Really tight. And then the one we did, Sheila, was with this obturator restorative technique. We put a bolster between you, and I have done this quite a bit in my life, and it's not comfortable. It hurts. You know, they breathe in, you guide them back. If you're a manual therapist, it's so cool. When they get done, they feel like everything's wider in their life. Everything's more open. Everything's more roomy. This is a really good technique to use for those individuals who have really a long-standing history of ankle stiffness. Their ankle fear is high. They don't know how to use their ankles and let them go. This is a good one because the more hip they have, the more ankle, Katie, they've got. So if there's a long, long history of ankle instability, consider this one. If there's a long history of anterior knee pain, patellar tendonitis, consider this one. If there's a long-standing history of anterior tibial and posterior tibial shin, consider this one. If there's a history of tibial stress fractures, consider this one. If there's a history of any torque going on below the hip or knee, consider this one. This is a good one, okay? Because it detorques that activity. It allows you to get more rotation and therefore detorques the tibia and the femur and the ankle. And then Janie is laying on her left side, and she's doing this left ischiofemoral ligamentous stretch. Okay, how? We're putting bolsters underneath her left knee to passively internally rotate that leg. Sheila, can't you just feel it? Nobody's touching you. You're laying on your left side. Your right foot's resting on that wall, and you're going to keep adding a bolster to that left knee until you can feel a posterior capsule stretch. Jen says if you reach out with that right leg as you have the bolster underneath your left knee, your left posterior capsule is going to start to what? Stretch. You shouldn't have a lot of TFL or hip impingement going on simultaneously if you do it. So that's a good technique to use for people who really are problematic in active activity. This is passive, and I like it as well. I like it as well as everything above that because it's a passive activity. I think we killed that. I hope we didn't go over it too fast. Okay? Why would you want to inhibit the inferior gluteus maximus? Oh my goodness, why would you want to do that? I thought we wanted our glute maximus to work. What glute max are we really trying to get to work? The glute max on the right side. Why would we want to inhibit it? Well, when you have decreased right FAER, you can't get enough external rotation. Okay? You can't get it. Decreased right FAER, not AFER, but FAER. And why is that? Because if you have a problem getting a Hruska adduction lift test of 1 or more on the right, if you have a problem with that Hruska adduction lift test on any side, you might want to consider an inhibitory technique for the most inferior fiber of the glute max. If the inferior, look, over time, folks, if I'm standing over here a long time and my inferior glute max gets really strong, it's really tight, I might want to stretch it out a little bit. And before you make a judgment on this, let me finish this and show you what I'm talking about. So I've been there for a long, let me go over this. Where I have my finger right there, if that's really tight on that right side, really tight, and I can't get enough motion from it when I externally rotate my leg, I can't get it because it's tight. I can't slip in external rotation because I'm in overextension on the right side. I'm in too much extension on that right side. Let me show it to you on the, I want to get her into flexion on my right side. Because on my right side, I'm overextended. I'm over tight. Remember you tightened those, remember you colored those 3 attachment sites? Between the sacrum and the trochanter, it's over tight. So when I try to externally rotate, I can't because it's all locked up. So I've got to get more flexion so I can get more external rotation for clearance. So I'm over restricted. I've been over here a long time. My hamstrings are active, my butt's tight, and I can't get over to the other side because it's overly tight. Did that make sense, Chad? I can't get over there and do this left AFIR and right AFER because it's overly extended. Do you need more flexion on the right side or extension on the right side when you shift over to the left side? This is such a weird discussion. You need more flexion on the right side. You need more flexion on the right side. So I'm going to stretch out my extensors on the right side. Therefore, I got to stretch out my inferior glute max extensors on the right side to allow me to shift over into AFIR on the left side. Does that make sense? On the left side, I need more extension, and on the right side, I need more what? Flexion. And we do quite a bit of this. We call this the adductor magnus inferior glute max quadratus stretch. And if we had more time, and I would encourage you next week to do it, get on all fours, go to page 56. This is not a hurdler stretch. Go to page 56, everybody. This is not a hurdler stretch. We're not doing it. Look at on the bottom of page 56 when you fail. When you fail. In fact, Karina, could I ask you to read this for me? I don't want to go through this one too fast. Could you just read it? At the middle of page 56 down, could you read this whole thing for me? It says right, read it all.
Right inferior gluteus maximus inhibition.
Before you go any further, Jen, we do not have this in our PowerPoint, right? No. Do we have the whole writing up of this? No. Go ahead. Read it for me.
Position yourself on your hands and knees. Bend your right knee and cross your leg in front of your left thigh so that your right ankle is in front of your left knee. Lower yourself onto your forearms and straighten your left leg. Keeping your back rounded, continue to reach back with your left leg until you feel a stretch on the outside of your right hip.
Stop. Did you hear that? Did you hear that? I guarantee you will love this. And I would even consider doing it on the opposite side because of what she just said.
This is pigeon pose in yoga. We do it all the time.
Say it loud.
This is pigeon pose in yoga. We do it all the time.
It's so cool. It's so cool. Keep going. Pigeon pose in yoga.
Hold this position while you take 4 to 5 deep breaths in through your nose and out through your mouth. Relax and repeat 4 more times.
Look at the hip. Look at the hip on page 56. If that hip drops, I'm going to find it myself because here's one thing that people probably need to understand. I want to keep the right hip up in the air. You don't want the right hip to drop like on the bottom of page 56. So tab that. This is a good posterior capsule stretch for both sides. It's a good stretch provided that you keep the hip what? Up. Then have they take a breath of air in, blow, and as they blow out, reach with that left leg going back without the right hip what? Dropping. If the right hip drops, you got a hurdler stretch. That's not what we're doing this for. So keep that right hip up. And I like that either way. Top of page 56, that's my daughter stretching her hip out. This is the only thing my daughter Rochelle got relief from as a cheerleader. That's what gave her relief because her hips got tighter and tighter. She's really narrow. If you see her, she's so narrow. And that's what got her through cheerleading was that stretch. Then you go down to page 56 in the bottom. You have to do the very same thing, but keep that hip up, and now you're getting more an exaggerated stretch of the inferior glute max. Those are my 2 favorite ones, and I don't think I've got too many more but those 2. Let's talk about plantar flexors. And I don't know, Lydia, what you have, but we want these plantar flexors to get longer. Okay, these gastrocsoleus muscles to get longer. Consider this technique. If you have decreased bilateral FAER, overactivation of the plantar flexors, has a positive Thomas test after repositioning, has an early heel rise. Circle it, an early heel rise, because you didn't stay on the floor long enough, Chad. You picked up a leg and you didn't stay down long enough, okay? So, gosh, bring out the squats. Do you see that squatting bar reach where the knees are going to the chest? I wish, that's Mike talking to us. Your back will round out. You will have counter nutation, counter rotation. It's okay. Do you see that? And that's all on page 57. Squatting bar reaches. Standing gastrocsoleus stretches. This is Paul Coffin, right? Can you see? I know Paul had you girls doing this. I'm sure of it. All 4 belly lift walks. All 4 belly lift walks. So your belly's tight, you're walking and you're stretching out those gastrocs, those plantar flexors. You go as far as you can without the heels, Dallas, coming up. Keep the heels down when you walk forward. Don't walk through it, walk to it. Because if you walk through it and the heels are coming up, you're not getting it. And it's all, Sheila, this is good stuff here. I mean, I know the downward dog and all this stuff, but this is a great thing to do to keep the heels stretched out. The long-seated hamstring stretches, outlined on page 59. The supine crossovers, touching your toe with your opposite hand. Great rotational activity, good AFIR on this side, with good co-contraction of left abs, left hamstring, reach up, right trunk rotation. Beautiful activity. Hamstrings are activated on this side by a stretch. Hamstrings are activated over here because of activity. It's got to hold you down to do it. The seated resisted punching with the left hamstring co-activated is a great activity. With the toes off the floor and the heels on the floor. I know I'm going a little fast, but these are all great activities to do to decrease that plantar flexion override or overuse. Okay, we're going to go back. Jen's going to reset this. I've got one more little area to talk about, and then we'll be done, okay? Are there any stretches? Are there any questions about this stretch or inhibitory program? Anybody have any questions about it? I know it's late, but those are all our inhibitory techniques. I want to just quickly remind you now, we're going to talk about some of the syndromes, and these are in your manual under the appendix. So if you look at where it says piriformis syndrome, sacroiliac strain, hip bursitis, I'm going to talk about a couple of them anyway. And I'm going to do this because I want to make sure you know how the manual's set up for them. And this is in your appendix. And there's a left one and a right one. And you know what, Bobby, you asked about this one. You asked about it. And I think we should talk about this, along with SI strain, left versus right. And we got this course done. So left, right syndromes. If you have a left piriformis syndrome, more than likely you're going to find the following test results. And as I look at that, I want to also remind you that I don't mean to skip over page 90. Page 90 in your manual is a page that was put together years ago. I don't mean to skip over it. I just want to bring your attention to it. Kinetic and kinematic issues related to pelvic femoral dysfunction. So this is a page that talks about obligatory activity. Go halfway down, and it says obligatory positioned elevated piriformis and gluteus maximus. To get there, you follow the arrows down, and to get there, you're going to have three things come off of activity that evolves around the obligatory position of piriformis and glute maxes that are working at a high level. You'll see leg length discrepancies, you're going to see tibial knee pain, and you're going to see overuse of the vastus lateralis as an internal rotator. All three we've talked about the last 2 days, but I think it's a great little summary on what's going on as a result of hypertonic lengthened hamstrings that are too long. So when that happens, piriformis and glute max are going to be obligatorily working too much. So remember that we're taking the load off the piriformis and the glute max with a hamstring program. So I don't mean to go over that too much, too fast. Let's just talk about this briefly. When hamstrings get too long, obligatory demand on the glute max and the piriformis goes what? Up. That's all I'm trying to get across. And the first thing that you're going to see are leg length discrepancies. The second thing you're going to see is poor patellofemoral congruences. And the third thing you're going to see is a lot of vastus lateralis overwork. And that's all outlined on page 90. We discussed that, but I don't want to go over that too fast. We've got to be mindful of that. This is a hamstring program. Start off yesterday morning that way. If you don't abide by the rules, keep the hamstrings strong and a little shorter, these obligatory issues are going to enter your life some way. One of those three is going to enter your life. So I see that page and I remember those days, and I just don't want to go over that too fast. We're on page 91 now because of page 90. Piriformis syndrome. Obligatory position elevated piriformis syndromes. So that's on page 91. Now I'm back to page 91. Let's put our mind back to the reason why you have piriformis syndrome. If Carl was here today, I'd say, Carl, what's the number one muscle that drops off that produces piriformis syndrome? And Carl would have said, which muscle? Hamstring. So Carl's not here, but I'm going to answer the question for him. Hamstrings. So any piriformis syndrome, I'm going to tell you, you need hamstrings. First thing you got to do is get those hamstrings and get back into a neutral position. If you have a left piriformis syndrome, you're going to have a positive adduction drop test on the left side. You need hamstrings to reposition that left side. If you have a right piriformis syndrome, you're going to have a positive left adduction drop test. You need left hamstrings. So right off the bat, for each piriformis syndrome, Carl, which hamstring do you need? And he would say, left. I need my left hamstring for both. That starts you off with a neutral position to treat either one. If you have a left piriformis syndrome, you're more than likely going to have decreased left FAIR. If you have a right piriformis syndrome, the piriformis is working really hard for external rotation because you have decreased right FAER. And you don't have the ability to kick in good external rotators on that side because you're in a constant state of what? AFIR. So you'll see those two values across the two FA joints when tested, more than likely. A left piriformis syndrome is going to have an adduction lift test on the right side of 2 or less. The abduction lift test on the right side for a left piriformis will be of 2 or less. Seated right FAER strength will also be very, very poor for a right piriformis syndrome. Most likely, all your left AIC pattern patients are in right piriformis syndrome. They just don't complain about it. So just say they're silent, but you already know the program, Eric. You're going to go through patient A. But the left piriformis is a little different. We're going to show you what we would do with those guys and gals, okay? So the left piriformis goals versus the right piriformis goals. The right piriformis goals are to decrease sacral rotation and spinal orientation to the right. Period. We already know that. We've been doing that the last day and a half. Nothing's new. And we're going to do that by getting that, and we're going to decrease the demands placed on the right piriformis as a right AFER muscle. We already know that. What muscle is going to replace the right piriformis on the right side, Pat? The right glute max. If you start with ER right away, you're going to irritate that piriformis really bad. So we wouldn't do that, Bobby. We would start with IR right away. So now you know another reason why you don't want to just start with ER right away. Start with IR on the left. Yeah, you want to start with ER on the right. IR on the left right away. On the left piriformis syndrome, you want to decrease left AFER, compensatory activity, left AFER. Because remember, left AFER is prevalent with left piriformis. There's too much piriformis work going on, along with too much glute max, along with too much external rotation everywhere on that left side. Pushing your femur which way, everybody? Out. Way too much external rotation going on. So you want to decrease left AFER, the compensatory activity, via piriformis femur attachments when it's in a left AIC position or pattern. So we actually want, this is kind of weird, we want that yellow color back in your life. We've got too much piriformis work with left AFER. We want the piriformis to work when you have left AFIR. We want to do that. We want to cinch that baby up. So here's the treatment considerations for left piriformis. And by the way, these are tough patients to work with. Because first of all, they don't even understand what left AFIR is. So you got to get there, you got to get them an ischiocondylar adductor. Look at the very first one. Left piriformis patients will love that first one because they got to figure out how to ischially move back that femur with an adductor in a state of IR that's passively been put there and with proper breathing. So this is the choice activity for left piriformis to start with. And then we want left sideline knee to knee, not toward, to. You want to touch it, know it. You want to close the clam. You want to keep it touched. We want both knees to know that they're touching, not just toward it, both adductors. Kick in a little bit. And the gluteus medius and minimus should be there. Now, believe it or not, in that position, when you bring that knee to knee, when you bring that left knee to the right knee, and that right knee is forward a little bit, that piriformis on that left side is going to be in a better position to work than it would be if that foot was turning all the way what? Out. So we want knee to knee, and that left piriformis that you colored yesterday was on the left side. We want that to kick in a little bit. Well, piriformis externally rotate the femur. How is a knee to knee going to help that? Well, if you go knee to knee, you're internally rotating. That means the external rotators are going to get what? Stretched. So your piriformis is going to get stretched out. And it's saying, oh, whoa, I'm actually getting what? Longer, not what? Shorter. So you're using the knee to knee to activate external rotation length. You're getting it longer. And that's saying, the body is saying, I haven't been there. Now, if I keep my knee to knee in internal rotation and I keep that there, my piriformis is in a better position to then start what? External rotation without my glute what? Max. Because I've got left glute med and mid and all this other good IR going on. So we're isolating it from the pack now, so to speak. Let's keep going. I like the bottom one, knee to knee. Then what you're going to do is you're going to go foot towards foot. You haven't seen this before. We're going to lift the foot up toward the right leg. We're going to go foot toward foot, not knee toward knee. And you're going to internally rotate and lift up that entire foot. We're going to get really, really sassy with this. We're going to make them work hard. Lift up the entire foot, adduct that entire foot. Or we can do left side lying, left adductor with right resisted right glute max. This is kind of weird because look at, they got to go up and then out. That external rotation is provided by what? Where's the stability coming from that band on the left side? The left piriformis. If you want to write down right here, the left quadratus femoris, the left obturators, the left piriformis are all going to be taking that femur into external rotation in an AFIR what? Position. You're retraining how to externally rotate without what muscle on that left side?
TFL.
The TFL and the left glute max. We don't want the left glute max on that left side. This is a very complex activity, but if you follow it this way, the piriformis syndrome on that left side should start to drop off. All of these activities with the right leg in abduction, the left leg in adduction, with the right glute max on to shut the left glute max off, will all help you. In other words, if you go up and down, up and down, up and down, as that foot stays in that position with you in the AFIR, bolster, no bolster, bolster, no bolster. All these activities will help you get that piriformis syndrome to shut off on that left side. A left piriformis that thinks it's got to be part of the left glute max complex because you're popping out of the joint is a bad deal. So you're teaching these people how to go into IR, ER, IR, ER. In what state? Left AFIR position. That's what a left piriformis program is all about. Man, look at all these pictures you have for left piriformis. Foot towards foot, the very last one. This is the NPRI myokin, lower extremity, lumbopelvic femoral activity. This is the hardest thing to do, this one right here. I believe, Jen, it's the last side lying technique, I believe. I would know what would be harder, because she's laying on her left side, she has her abdominals on, she's giving me left adduction with left internal rotation. She's barely tapping and holding on to the floor, and she's lifting that foot towards foot. Very hard thing to do. And if she can do that, that should totally diminish your ability to kick in all those small 6 external rotators. So all it is an inhibition program for the piriformis on the left side. Piriformis on the left side challenged me in my career more than any other muscle, left piriformis syndrome. And you're going to see in a minute, so did the left SI joint. left SI strain and left piriformis challenges me more than anything else in my historical memory bank. Toward the end of treatment, if seated left FAIR strength remains weak, you got to work on glute med strengthening without kicking in any external rotation on that left side. Now for the right piriformis syndrome, posterior hip capsule, just write down posterior hip capsule. So have you ever had any right piriformis sciatica? Still do? Okay. Not very often. Posterior hip capsule, posterior hip capsule, posterior hip capsule. Just write that down. Supported left AFIR with right psoas and iliacus and right FAER. So here's Katie. She's sitting here. She's doing a lot of left AFIR, kicking in the right psoas to kick the spine over to the left side to keep that left posterior hip capsule, opened up on the left side. Okay. This is Drew's wife, and she works over in the clinic right now. So she was a former patient of mine, and now she's a therapist that I have as a colleague and a friend. So she's showing you a great way to get the right psoas, right iliacus, right FAER working without the piriformis working while she's staying in left AFIR. Retrostairs is a good way to treat right piriformis syndromes. Toward the end of treatment, if right FAER strength, and it says FAER, not AFER. We're doing FAER without the piriformis working by keeping left AFIR. So you're kind of doing right FAER on right AFER. If your strength remains weak, attempt to do left sideline, right resisted glute max, but you got to be careful because if we do, you might kick in the right piriformis. So you got to do right glute max work with maximizing left AFIR capsular stretch. Now I know it's been a long 2 days and these words are just flowing out, and the advantage of the people that are watching this at home, they can replay it. But some of you here aren't going to be able to replay it. So I know it's a lot, but you do have a manual to go through if you have these syndromes. And the only other one I want to talk about today is this SI joint strain, okay? Right SI versus left SI. Page 94. It's kind of fun. Right SI patients need right glute max. That's it. They need right glute max with concomitant left AFIR. So what you do is you lay them on the left side, you keep their right glute maxes on, you can use a band, or you lay them on their back, you keep left AFIR alive, and you do a lot of right glute max work. So I could push this right leg down into ER with a pillow or some other bolster here, or I could put a band here. Your mind is the only thing limiting you, as long as you keep the left hip in left AFIR. That's to close the right SI joint. Remember the gap yesterday morning as we went down the MRIs? You saw the gap get bigger and bigger on that right SI joint. To close that gap, you need right glute max closing it. It's a triosseous muscle. To safely close it, you need to do it in left AFIR. Take home message. Dallas, left AFIR, right glute max seals right SIs. All of these activities are awesome for right SI joint dysfunction. So we put together a little cheat sheet for you. You know, Karina, when you go back, these are all good little techniques for right sacroiliac strain. A lot of bands. You see all those bands? There's a lot of bands here. I got 1, 2, 3. There's 5 activities. And I know it's been a long 2 days, and there's a lot of terminology coming out of my mouth. And this is the example, but this is really good bread and butter stuff. Look at this, 90-90 resisted right glute max with right FER. See that yardstick activity again? This is Pilar way back then. Pilar was doing this. She had right SI pain, and she was a PT assistant for us. Now let's talk about left iliosacral strain. And did you notice what I put down there? In fact, if you kind of look, I don't know how many caught it. The first one says right iliosacral strain. I didn't say right sacral ilio strain, right iliosacral strain. Because you realize these SI joints, the problem isn't the sacrum. The problem is what? The ilium. So now we've got this left iliosacral strain. What are you going to focus on, guys? Left ischiocondylar adductor, period. Left ischiocondylar adductor pulls that left SI joint together again, along with the left piriformis. So this left ischiocondylar adductor, after achieving left AFIR, you really want to keep that left ischiocondylar alive. There's nothing on page 94 that should surprise you. These joints are hard to close when they start talking. This left SI joint is really hard to close. So anything that's going to keep the left abdominals co-activated with the left ischiocondylar adductor is something to be cognizant of. So that's why I like left side lying activity for left abdominal work with left ischiocondylar adductor activity. That's this one way down here. Look at this baby. This is a good one. This is my favorite. In fact, this is the only time you've seen it in this last 2 days. Look at this. Left abs, left inner thigh, left anterior glute median min, no TFL, right glute max, right arch. This baby is in left. She is not going anywhere. That's closing the left SI joint. In fact, that would be the technique. But all these other techniques are really good techniques to help you find that ischiocondylar adductor. I don't need to say too much more. This one was a staple of my handouts for years. Left inner thigh, left glute med. This foot's lined up with the pube, but this is still the cake taker right here. This is the one you want to look at the most. On page 95, I'm not going to go through all this. Things that you can consider for hip bursitis. Hip bursitis on the right side is basically around this definition discussion, where co-activation of the left ischiocondylar adductor and right glute max does not exist. You do not have it. So basically, we're giving you activities that will help you get that co-activation of it. IC adductor on the left with a glute max on the right. Just that bursitis on the right side is because you're working too much. You're in a too big of a adducted pattern. People hurt out here because they're way out here and they're shifted way over there. They need adductors on the left side to decrease that right transfer of weight shift. They're way too far out to the right side. They have sharp angulations. You know, you look at their hips, Eric, and they've got large hips, narrow little torsos, and they're still in right side AFIR and they hurt. Right bursitis is a pretty common thing with especially women with large hips. But men that land on their hips, they can't heal it up. They need AFIR on the left and they need right glute maxes to help them out. So here are the examination considerations, and then the intervention is outlined for you as well. These are all good things for right hip bursitis. Jen, I'm going to let you talk for a few minutes. Is that okay? Would you do that for me so I can get a drink of water? Jen's going to talk for 10, 15 minutes, and we're done. Are there any questions? That was a lot of stuff. And it kind of rolls off my tongue. You know, even for me, you get to a point where you can't absorb anything more, Chad, but you at least have in your manual a section to go to where you can look at these syndromes and at least get some guidance. And we picked out the ones that we think you're going to see the most as relates to myokin. Jen does a lot with the Institute, so she's going to talk to you about some administrative issues, and we should be good. The main thing is there any coffee left, Jen? That's the main thing.
Okay, so just briefly, shouldn't take longer than 5 minutes. One of the things that we are probably most proud of here at the Institute is that we have the ability to offer clinical support. So taking a continuing education course with us doesn't mean it stops when you walk out the door or when you turn off your DVD at home. We want to provide you with the resources needed so you can be successful in implementing what you have just left with. Commonly, people have lack of confidence when they walk out this door. You'll be all excited today and tomorrow, and then you'll start seeing people this week, and you'll be like, I don't even know what I'm doing. Like, I don't even know. Maybe I didn't learn anything in that class. So lack of confidence, don't think you're the only one. Trust me, I think probably everyone goes through it. Lack of group collaboration or clinical support. Some people are going to go home and they have a couple of PRCs in their clinic and, they don't lack clinical support or assistance. And others will go back and they're the first person in their entire staff that's taken any PRI course. So they're kind of, like, I don't know what you're doing, good luck, type thing. So they don't have that support. Or, some people have the cost, location, schedule conflicts to go and take that next course so that they can continue to build on what they got from this course. So that's where we come in. We are here every Monday through Friday. We have multiple people on staff. We answer phones. We'll help you out with your questions as it relates to this course content material. We can't help you treat a patient because legally we will get into trouble if we're trying to treat patients across the country and internationally and via email and such like that. But if you come and you're like, I don't understand this concept on page 58, can someone walk me through that? You can email us, you can call us. All this information is available on our website. But just shoot us an email, give us a call, that's what we're here for. I'm a physical therapist, athletic trainer. Matt is an athletic trainer. Ron is always available to us if neither one of us are able to answer the question. We reach out sometimes to other faculty because sometimes it'll be like, well, James said this or Mike said that, and we're like, well, we're not really sure what they meant by that. So we have we talk a lot, we converse a lot, and we're here to make sure that you don't leave here super confused on any concepts. This appendix, as you have seen, and we've been flipping through it this afternoon, is full of techniques. We want you to use those techniques. We really do. So we want you to make copies of them. We want you to hand them out to your athletes, to your clients, to your patients, whoever you're working with, your mom, your dad, your grandma, whoever you're working with, we want you to hand those out. We just ask that you keep the copyright on the bottom of them so that they know where they came from. And if you ever are in, want the digital access, that's where the CDs come in to effect. But again, you can make copies of these as many times as you want. If you're doing an in-service or anything like that, again, we want to help you and support you. We have a copyright permission form on our website that you can fill out. It's real quick and fast. If you want some of these basic tests or pictures to use in an in-service, maybe you go back and you're like, I want to educate, the other 4 or 5 colleagues I have on what I learned this weekend. Shoot me an email or fill out that form, and we'll help you get the materials so that you can use the copyrighted material with permission. And then our website. We try to keep our website, designed for you. We're always trying to make updates to our website. So we want you to browse around our website. There's a lot of material on there. Some of it people don't find for years, and they're like, man, where did I miss this? There's a recent email section that probably has 50 to 100 different recent emails. We're trying to add to that each month. We have a blog that we update each week, sometimes with just how different courses went, different concepts that people talked about. Sometimes there are questions that come in that we put up there. We do featured interviews with different physical therapists, chiropractors, athletic trainers, all kinds of professions that we feature on our website. And then there's articles, case studies, references. There's probably over 500 references. If you look at every course individually, they all have a reference tab. And so if you ever are questioned by someone that says, where's the references? Literally, there are a ton of them listed on our website. But just browse our website, and then as you guys know, because we're filming this, we have home study courses available. So Bobby, you're in Texas, so you may not be able to get to your next course right away, but if you're like, I'm just, chomping at the bit to get the next material, We have home study courses. They're all now available online. So if you're interested in any of those home study courses, our introductory or primary courses, myokinetic restoration, pelvis restoration, and postural restoration are all available online. The secondary courses will probably never be available online. We talked about this numerous times. It's just those courses are a lot more difficult to keep the same content at every course because you're a lot of times talking to who's in the room. And in those secondary courses, you have a lot more experience, you have a lot more different questions coming in. And so these primary courses, there's one being taught today in Vancouver, and it's being taught the exact same way that this course is being taught, this myokinetic restoration course. Those secondary courses tend to get a little bit off topic and kind of down rabbit holes, which we want. They're secondary for a reason, but those will always be offered as live courses. And again, call with any questions. That's what we're here for. That's what we're proud to offer this service for. So we appreciate you guys coming and sitting through this home study video. So just to leave you with a quick, funny joke that I don't know how many years old this is, but we assure you these are all standard exercises. Everyone knows how to do them. No one should give you a funny look when you hand out these handouts.